Thank you for joining us today. It's nice to see a packed room. Today, it is my pleasure to introduce our speaker, Dr. Mikko Finnila. He is currently a researcher at the Faculty of Medicine, University of Oulu in Finland. He has an extensive background in biomedical engineering and musculoskeletal research. He started by earning a Master of Health Sciences in Biomedical Technology from the Faculty of Medicine at the University of Oulu in 2018. And then he went on to earn his PhD in anatomy and cell biology from the same university in, I think I have the dates messed up because you can't earn a master's in 2018 and then go on to earn a PhD in 2014, but we'll go with that. He did additional research in the Department of Environmental Health, National Institute for Health and Welfare as well in Finland. And then he followed his PhD by completing a postdoctoral fellowship in the musculoskeletal disorders research area, focusing on biophysics of bone and cartilage in the University of Eastern Finland. He also then went on to earn a title of docent in biomedical engineering from Finland in 2020. And a fun fact that he's highlighted in his background is that although most of his academic training has been at the University of Oulu in Finland, he has gained a lot of international research experience, which he will talk a little bit about in his background. He was also here in Calgary in 2015, I believe. And outside of his research, he enjoys running in nature and strength training. So please join me in welcoming Dr. Mikko Finnila. Today he will be presenting on animal models for post-traumatic osteoarthritis.
Can you hear me? Good. So today I'm gonna talk about animal models for post-traumatic osteoarthritis because that was the main topic that I was working here back in 2015. But before I go to the animal models, I'm a little bit gonna show you that where I'm coming from. So this is a European map, and then we have Scandinavia, Norway, Sweden, and Finland, and always located over here. And when I was here in 2015, I was actually representing different Finnish university, which was University of Eastern Finland, and they have two campuses at Kuopio and Joensuu, and Rami Korhonen, for example, who I think worked 2 years with Walter, is from Kuopio campus. But if you wanna see some nice pictures, I think this kind of applies to most of the Finnish cities. They are cold and they are beautiful. This is probably like, okay, it's not always beautiful because in December and January we have pretty much all like darkness, but this is how it starts to look in spring. It's icy and bright, a little bit like Saskatoon, where I have been also multiple times. I can see that Calgary has grown a lot. I think it was like 1 million people when I was visiting 2000, and the city has grown a lot. So Oulu is much smaller, around 200,000 people with really young average age because it has a university and also like other higher education institutions which attracts a lot of young people. Before COVID, we used to say that Oulu is a nice place because it's easy to go away from there. But now that the flight prices are super expensive, it's not so easy to go away. But basically, we can travel quite easily from Oulu. We have nice connections to the rest of the Europe and globally. Something that is also very typical for the people who are living in our region is that everybody wants to own their own house. And pretty much everybody is living at their own house. And the area is quite large and there are not too many people and it's really affordable to do so. And at the same time, it's really safe and you're pretty much everywhere in the city within 20 minutes of driving. So if you think about Finnish industry, what comes to your mind?
Lumber.
Lumber, yes, we have We don't have lumber in all, we have pulp. So kind of a process engineering is one. Anything else from the Finnish industry? Huh? Who remembers Nokia phones? Huh? They are gone. We went with Microsoft, and I think that's the kind of end of Nokia, which is a pity. And who many of you are studying kinesiology? Hands up. So have you heard about polar heart rate meters? So they are from O. How many of you knows what is this? O-ring. That is also from O. It's owned by, so Polar is still really heavily owned by old people, but Aura got so much like capital funding from the States that it's pretty much like USA company nowadays, but they still have like the main RDI site in Oulu. Something that we are also quite famous, I don't know how cycling is here at Calgary, at least the city center doesn't look like too much of a cycling friendly city, but we would prefer to go cycling everywhere, and we have 900 kilometers of these pedestrian roads in Oulu. And we are culture capital of Europe this year. I don't know how you can see it. Do you know what happens here? So we have this World Championship of air guitar playing. I'm gonna quickly go through. I'm just gonna mention that the university where I'm working at, it's one of the multidisciplinary universities in Finland, and we have pretty much all the disciplines. There's only one Finnish university that has kinesiology, or actually in Finland it's called sports medicine, and that is in Jyväskylä, so that is something that we don't have in Oulu, but pretty much all else. And you could see that those previous ones were the official marketing slides, and now I have something for the students who wanted to visit Oulu. So this was the old marketing picture for exchange students, which was saying that if you can manage here, you can manage anywhere. But anyways, to continue, so 2008, I think the year was wrong. Previously, I got my kind of a undergraduate or master's degree on medical and wellness technology. And why it's wellness technology? It's because we were from Oulu and we had a lot of these wellness industries, and the university wanted to profile accordingly. I didn't go with that direction. I studied biomedical technology, so much more like biomechanics, biomaterials, cell engineering. And then I didn't want to go to industry, so I stayed in academia and I did my PhD on bone toxicity of environmental pollutants in 2014. And then 2015, I had to go to do postdoc somewhere else. And I went to work in University of Eastern Finland. And I think, I cannot remember if it was already the 2015 that in autumn, I came here for 6 months, or I guess it was in autumn. And then there was 1 month in 2016 that I worked with Dave Hart at the Foothills. And then there's this funny title, adjunct professor. And why it's important for Finnish people or any Scandinavian people, it's basically driving license to supervise PhD students. So from 2020, I have been eligible to supervise doctoral students. And that's the only thing that this adjunct professor or title of docent needs. And then on 2022, I got Academy Research Fellow, and that's the best thing that can happen if you're a Finnish academician, because it's 5 years of independent establishing group, and you can focus purely on the research. But I'm gonna go now a little bit back, and I'm not sure if Walter has seen, so these might be not so good looking pictures, but I start with something that I started when I had just finished my doctoral training, and I was thinking what to do as a postgrad. And I got excited about phenotypes in osteoarthritis. And what do you think about osteoarthritis? Is it like single disease or like who thinks that osteoarthritis is a single disease? No. Who thinks there's more than 2 types of osteoarthritis? What about 3? 4? So I don't think it's been really shown, but there's like that this osteoarthritis is an umbrella term for joint diseases. And there's a multiple types, and you get different phenotypes of osteoarthritis depending how they start to form. And because I'm a simple person, I wanted to start with something that is easily explainable. And one of the osteoarthritis phenotypes could be post-traumatic osteoarthritis. And I'm saying that post-traumatic osteoarthritis is a simple thing, but it's easy to say that you have a trauma that results to something that results to osteoarthritis. In sometimes it might be even more complex, but this was kind of my concept when I started to work. I did bone and environmental toxins, and straight after the doctoral training, this was from the first proposals. And I must say that visually this is not so appealing now that it was when I had graduated, but I didn't have too much time to push. But anyway, I was proposing that you have the post-traumatic, genetic, metabolic, age, and pain-related phenotypes, and I wanted to focus on the post-traumatic osteoarthritis. And we established a project around this. And this is the animals that we did. We had 1-year-old female rabbits, and we induced the post-traumatic osteoarthritis. Actually, it was Andrew, and Andrew was massive help. So I'm gonna tell a little bit later more on the measurements that we did, but he was massive help, and he did the surgeries on these rabbits. And we had 2 time points, 2 and 8 weeks. And we had the idea because there was one Finnish person here before us, no, actually 2. So Jimmy was working on the meniscectomy model, and Siri was working with the ACL. So we had the idea that we would have at the end this kind of a time trajectory from 2, 4, and 8 weeks. But I tried to remember to tell that why it doesn't work, but we worked on the 2 and 8 week time points. And we had 2 groups, so kind of a mechanics rabbits where the focus was really to do mechanics and imaging without tissue fixation, etc. And then we wanted to get idea on the biological events on these animal models and why the post-traumatic osteoarthritis develops. So we had this biology rabbits on the 2 weeks time frame. And this was kind of a like how I tried to put the biology and how they are affecting tissue related changes in post-traumatic osteoarthritis. We didn't manage to do everything, and some markers we were able to measure only from certain places. But basically, the idea was that there's a really strong inflammatory response straight after the trauma, which results to increased MMPs, so proteases in cartilage. Comp was something that we never looked. then on the interface, we were expecting to see this kind of a differentiation of chondrocytes, that the cartilage cells would actually become like bone cells, and that first there would be increased vascularization in subchondral bone, and that by 8 weeks we would already see sclerotic subchondral bone. So these are more like methods that what we did. And I'm gonna this but how the days were here. So when we had the necropsy on a morning, we collected blood, synovial fluid, and then I think it was Andrew who was proposing to why guys you don't collect collateral ligaments, and we have now. We collected those even it wasn't in the original plan, and we collected fat, menisci, and we performed this macroscopic grading. And what we did with the actual joint surfaces was that we cut them in the smaller pieces, and we embedded those in the dental cement so that we can do textron staining and propydium iodine. So we wanted to see that which cells are alive and which are dead, and to measure the cell biomechanics on the living cells. And if somebody is interested to do this project, again, don't use text, go with Calce. I think it's much better choice for the segmentation. And we measured these from 2 femoral medial and lateral compartments from femurs, tibia. Then we measured one side from groove and patella. So this is like 6 sites. Doing all that confocal work with the necropsy, it took 36 hours in row. And it was quite a bit of work. Then we froze these samples after measuring the cell biomechanics and shipped those to Finland, where we did even further kind of a mechanical characterization, so stress relaxation tests with dynamic DMA test at the end, which is not plotted on the graph. And again, this is more like a continuing how we continued in Finland. So we did OCT to figure it out what is the thickness of cartilage, quantitative MRI. Then we fixed samples. We did 2 types of a micro CT, histology, and from the histology we did suffering all for RC grading, polarized light microscopy and digital densitometry. And I was just counting 2 days ago that what has been the results after 11 years, and I found 14 papers so far from these rapids, and I think there's still a few more coming. But let's continue more on the result side. So when you do this confocal imaging and in situ biomechanics, you do the unloaded state, and then we applied, I think, 10 megapascals loading and let it relax and measure the cell volume again. And you can then quantify changes in volumes. And this is something that we have only been analyzing for the 2 weeks time point. So this is for the 2 weeks time point. And we can see that pretty much everywhere else, except in the lateral compartment of the ACLP rapids, the cells are getting smaller when they are being loaded. And this kind of a volume change effect disappears in one single compartment. And we were interested, I think it's gonna come late, but this is then from the results that we did with Dave. So there's a thing called mechanotransduction. And I still don't know what is the best molecule trying to quantify mechanotransduction, but my favorite in this work was DKK1, which is also on the same pathway as the sclerostin. And for cartilage, you don't have sclerostin, so that's why we stick with the DKOP1. And if you remember from the last one, there was a changes when you compared different sides. So this lateral side of the ACLT animals showed the difference that you don't have anymore the cell deformation. The cells don't change volume. And this is the same side where you have like group-wise difference increased on the DKOP1 thing. Then we measured the core gain for proteoglycans, Aggregan, and what we were surprised was that it was increased in all the ACLT animals. So in the diseased animals, you had increased matrix synthesis, which was quite odd for us, but I can show later that why it made sense. Then I have been always interested on oxygen sensing. We measured IF1 alpha, which was also increased in all the sites or all the locations in the knee. And that should be really like an anabolic signal for chondrocytes to produce more matrix. But the damage or this mechanical overloading should decrease that. Then IL-6, so interleukin 6, and this is something that I haven't been able to wrap up my head around. So we measured IL-1 beta, which is classical kind of a marker for inflammasome activation. And then IL-6, and I'm not sure if this IL-6 here refers more to kind of a tissue damage or the inflammation, but it was especially high on the medial side of the operated animals. And like I had the hypothesis that you have increased amount of proteases, that we were able to solve pretty much on all the side of operated animals. Then going a little bit back on the biomechanics. So this is the biomomentum data. I showed already previously the loading protocol. So we were able to show changes in equilibrium modulus, in the femoral condyles, and it didn't really matter that which group comparison you were doing. They were mainly in medial, in femoral condyles. So cartilage, for me, this means that cartilage changes first in femurs of these rabbits. And this is a quantitative imaging on the proteoglycan density. So you can quantify the fixed charge density on cartilage by doing safranin O staining and digital densitometry. So it's a just quantification of the red color on the samples. And you can see here already that you have reduction in the operated animals. And here's the 2 and 8 weeks comparison. I hope that I have this here. So you have some changes already on the 2 weeks time point, especially on the femur, patella, and those femoral condyles, red one being the ACLT. And if you look what happens on the 8 weeks, the femoral condyles are getting worse. But what about lateral tibial plateau? There's not much going on at all. And this femoral groove and patella, they seem to be actually even getting better. That you have more proteoglycan, or that in 2 weeks you have loss of proteoglycans, which has recovered on 8 weeks. And we were talking with Andrew this morning that whether you can reverse OA. most likely not, but something can happen and you can have a little bit improvement on the tissue properties by 8 weeks in cartilage. ORC score, so the histopathological grading of the OA severity. And one of the reasons why I wanted to do animal models was that I was thinking that it's straightforward and controlled. But what we were really surprised of, personally, I was really surprised at the end, was that you had actually quite a bit of idiopathic OA on these 12 months old animals. So if you look, the ORC grades already at 2 weeks, so you have sometimes really high grades. Well, of course, it was further pushed with the ACLT, but for example, if you look at the controls here, I cannot remember which site this was, but in some sites you had increased ORC grades in the controls. Then the first thing that we did in Finland was this quantitative MRI imaging, and we quantified various quantitative reduction times. And I guess it's not surprised that we saw a lot of changes, which again were mainly seen in the femoral condyles. So what about the bone? We did 2 types of micro CTs, and the reason was that we had the 4 weeks time point, and I was really interested on what happens with the vascularization. So we had to have for these animals like really high resolution data, but we did also same low resolution imaging that was done on the previous animal models, because we wanted to have this trajectory that what happens from 2 to 8 weeks in the subchondral bone. But I have to say that these animal cohorts at the end, they were so different that we were never able to combine fully these 2 different cohorts. So we couldn't get the trajectory for that reason. Okay, so I'm not sure how visually striking it is, but we saw already minor changes on bone erosion at 2 weeks. And if you remember what happened in cartilage, that you had a little bit recovery, this bone erosion is even stronger at 8 weeks. So we are not even close on this turning point that when the bone starts to become sclerotic at 8 weeks in the rabbit model. So 2 months is not enough to model sclerosis in the rabbit model. Then I have been interested on a little bit kind of a more exotic things, or things that maybe others haven't been really looking at. And one of these is type or like calcified cartilage. Who knows what is calcified cartilage? Few. So calcified cartilage, you have first the articular cartilage, and then you have the subchondral bone. And this subchondral bone has this really wavy interface between hyaline cartilage. And when you go deeper in hyaline cartilage, you have something called type mark first in the histological sections, which is the front where you start to have mineralization. And these collagen fibrils from cartilage continue until bone, and then you have cement. But basically, this calcified cartilage is mineralized. And I think we have been a little bit having arguments sometimes with, or not really like arguments, but there's this old paper, I think it's from Radin 60s, that says that when you place metal rods inside subchondral bone, it denses or it stiffens the cartilage. So there was kind of an idea that how the increased thickness of subchondral bone plate could increase the stresses in cartilage. And that's why I've been interested to see kind of that how this subchondral bone grows towards the articular cartilage surface, and that happens in this calcified cartilage. And one of the theories related to OA development is called advancing tight mark, which means that this mineralization for articular cartilage would reach kind of at the surface of the articular cartilage, and you wouldn't have that anymore over there. So this is what we have published. It wasn't an easy thing to segment, so we had done manual segmentation, developed neural network to automatically segment this, and we were able to show that, or we showed already that there's a lot of site-dependent changes on the thickness of calcified cartilage normals. And then if we look at what happens with the operation, it seems to be getting a little bit thicker on femoral condyles at 2 weeks, and it's statistically significantly thicker in ACLT operated knees at 8 weeks. And the similar thing is pretty much shown on most of the site, with small exception of medial plateau, where at 8 weeks the calcified cartilage thickness wasn't increased. And this is that's still on those back burner papers, so we haven't published the results for those calcified cartilage results. And this is another thing, the porosity of the subchondral bone. And although we kind of fine-tuned everything, it's a still super annoying segmentation problem to finish. But what we were able to show, this is from femoral condyles, that the porosity, which we think is related to vascularization, increases in the operated knees. So I'm not sure if I managed to convince, or actually I have that data still to come, but I think there's a strong inflammatory reaction going on, but it might not be actually related to the trauma, and the surgery is a little bit exaggerating that on the ACLT model. But you have strong inflammatory response that results to degenerative changes in both bone and cartilage, and by the 8 weeks you don't have any sclerosis, although you can see some tight mark advancement. And one interesting thing I think in this material is that there was the recovery of the proteoglycans by 8 weeks. So ligament data, we did FDR imaging, polarized light microscopy, and from the FDR you can get composition, and you can see this kind of a zebra pattern in the polarized light microscopy. So this is the waviness of collagen fibrils, and you can then quantify so-called crimp angle for these fibrils. And there's a lot of data over here, and this is 8 weeks time point only, because nobody had done any ligament work before we decided to start with 8 weeks. And we can see that there's actually increased amount of amide, or the amide 1 peak, which kind of for our perspective is increased collagen amount. So you have more collagen possibly on the ACLT operated animals, and then you have changes on how this collagen is folded. So you might have actually more ECM, but it's structurally not so well organized as it's in controls. And there's also like a finite element studies, which is supporting or kind of indicating the same thing, that especially the collagen organization is not so good on 8 weeks. And something really odd that we saw was that the ligament biomechanical properties is related to ORS. What was ORS? Histological grade in cartilage. So ligament properties almost linearly decline with increasing ORS grade. Then the mechanical testing schemes are again stress relaxation test followed by dynamic mechanical analysis on various frequencies. And we could see especially changes on lateral collateral ligaments. So of course you don't have the cruciate ligaments, so we were looking only at collateral ligaments, and they showed changes both on elastic and viscose properties, especially like storage modulus, loss modulus, but also increased we couldn't show the decline for the ACLT group from the controls. So, and this is quite typical response that you see in these animals, that you have controls, contralaterals, and then the ACL. So this is the operated, the gray one. So there seems to be compensatory mechanism that this contralateral in all the parameters is stiffer or more viscous, and then the greatest change appears between the contralateral and the operated animal. So within the animal. Then on backpack, there have been, I think, nice work coming from here related to metabolic ON, and some people have looked backpack more. But what we did for this was liquid chromatography analysis on what kind of fatty acids you have on the 2 and 8 weeks ACLT group. And from here, you can kind of indirectly consider that which fatty acids are pro-inflammatory or anti-inflammatory. And our data indicated that there's an increased or kind of a shift towards the pro-inflammatory direction when you quantify the fatty acids in the fat pack. And I'm pretty sure that there's many other interesting things going on in fat pack than just changes in the fatty acid composition, like fibrosis, etc. So many small cool things, possibility for recovery, but even more important is that how kind of a systemic disease the osteoarthritis is, and how when you do osteoarthritis research, you shouldn't focus just on single tissue, but look the whole joint, what's going on. And it is a complex phenomenon. And kind of was some coffee break that what Walter was saying that guys, you should really look different interventions on these animal models that and that's actually something that I wanted to kind of continue on the later period. So we are still working, there's more work gonna be done on that rapid model, but really to start working towards therapies. And this was kind of a starting when I returned from Kuopio to Oulu. I cannot remember what year that was, but there was Johanna Huhtakangas who actually had developed calcipotriol therapy. So this is a vitamin D derivative, and these are pictures of the synovium. And in this model, we saw the reduced inflammation on the synovium. And why I have only the pictures of the synonym. And what is the kind of one lesson is that it's a really tricky to select which kind of animal model you're using. So this was with Simosan, and it's kind of a bacterial peptide derivative to stimulate rheumatoid arthritis. And we read all the papers that there was on the Chymosan-induced arthritis models. We did first trials, and what happened is that the whole knee kind of melted. We had to pause the experiment, and then what we did, we reduced the amount of Chymosan, so this inductor, by half, and nothing happened. So we kind of didn't have good disease model to test this therapy at the end. Then I have been doing a lot of work with Mansi Zenofi from ETH Zurich, and like what my current group has been especially now doing is contrast enhanced microcomputed tomography, and we are trying to push at the moment kind of beyond all the tissues. So having one modality that shows all the important features. So we do phosphotungstic acid staining for cartilage that we can then image with micro CT, and you can see these nice surface fibrillations. And if you think what the pathologists are looking from that ORC grading, it's those surface changes. So we can do indirectly quantitative pathology by quantifying the surface changes in this model. So basically we have this small window. We estimate where the healthy surface is and compare the local angle between the actual surface and the healthy surface. And from that you get kind of a local angle that you can then visualize as these kind of maps. So you get average histopathological score, but also like comprehensive visualization where you have damage in these animal models. And all the scripts and everything is openly available with the publication in OAC, and there's a QR code, which I'm not fully sure if it works or not. But anyway, you probably can find it. And so the model that we have been really working on is collagenase-induced osteoarthritis. So you can do this more like epitope-induced arthritis model, which is a different. That's a rheumatoid arthritis model, and this is just collagenase injection in the knee. And what does it do? All cases are good because we were wrong in the beginning as well. So our idea originally was that, okay, it degrades a little bit or softens the cartilage surface, what happens in the trauma, and you kind of stimulate post-traumatic osteoarthritis because of this softening of the superficial cartilage. It didn't turn out to be like that because in cartilage you have type 2 collagen, and what it actually did, it loosened the ligaments. So it's especially strong on ligaments, and for some reason we got really strong inflammatory response of this synovitis in this model. And you can see also that the cartilage surface is really degrading. And this is the model that we then have been now really characterized thoroughly. We know how it works. In 60 days, you can quite systematically simulate the generation of osteoarthritis, start testing therapies. And this is one of the first ones that we tested. And it's this kind of a brush-like polymer. And I think there have been some groups in the States who have had similar idea that when you have cartilage degeneration, you have these free amine grooves coming up on the surface of the cartilage. So our idea was to develop something that can bind to these degraded areas and provide lubrication for cartilage that would allow them the healing of cartilage. But when we followed up this for 60 days, it really didn't help, and actually you might have even stronger loss of proteoglycans on this one. Then we moved to kind of a sweeter ionic polymers, but pretty much the same thing. These are polymers which binding and charge you can modulate based on the pH and their composition. And then we had another study where we conjugated dexamethasone, which is typically used as a positive control in many of the OA studies. And kind of a technical improvement that we applied on this paper was that we have now also the bone parameters analyzed, but even the dexamethasone conjugated in these polymers didn't really improve the thing. And this is the final bit of hope. So this is the final vehicle of biomaterial that we have been testing. So TDF beta conjugated sweeter ionic polymers, and you can see that the white surface remains quite nice, and you don't have that strong loss of proteoglycans of those animal models. So it's kind of a how quick you can model the disease, and also that you really need to, at the end, characterize the OA model that you're using for drug testing. But maybe there's some hope for finding something that works forward. And that's for my presentation, and if you have any questions, please ask. And I have one more nature picture. There's two groups from Finland that are working together, and this is springtime. And if you are interested, it was great fun to visit here years back. And if you want to get some kind of similar experience from Finland, please be in touch.
All right, with that, the floor is open for questions. Who's our first person that would like to ask me? There you go, before it has to go. Right.
Can you talk a little bit more about the marching of the tide mark? Because you had the control group, which I assume did not get the ACL transection, nothing happened.
Nothing.
Then you had the ACL transection, and then you also looked at the contralateral limb, no ACL transection, right? So I was kind of expecting the contralateral limb to look more like the control limb. But I could have been mistaken, but when I was looking at the tide mark methods, or sorry, the tide mark figure, it looked to me like the tide mark was moving on both the ACL transection model as well as the contralateral limb.
Good point. I gave yesterday different talk on McCabe seminar. And we have done similar work on humans where we have compared medial and lateral compartment from healthy controls versus the surgical waste material that we have got. And where we see biggest changes on the human material is on the lateral compartment, so the unloaded side. So you could here argue and expect that, okay, you should see biggest changes on here, but because it changes the loading, and we don't know really like what drives the advancement of the tide mark, whether it's the increased loading, unloading, there can be like this inflammatory stimuli that are changing the phenotype. You get more hypertrophic chondrocytes on some, but it's a good point. And I hope that the reviewers don't figure it out as later. That
Well, I mean, it's interesting because it points to something maybe systemic if it's not due to the mechanical loading. The other thing that, this is an unfair question. But a few slides before that, I forget what you were talking about, but you said, this kind of suggests to me like it's the cartilage that's playing a role in the development of the osteoarthritis. The cartilage is going first. I think you said something like that.
Yeah, so
Wait, let me just finish the thought. But if you're looking at the tide mark and you're seeing advances in the tide mark and changes in secondary endochondral ossification, then that suggests it's bone up. So I guess I'm gonna ask your opinion. Do you think this is cartilage down? Do you think this is bone up? Do you think it's both?
both.
Yeah.
And something that I meant to say, and I realized that I wasn't able, or I didn't do good work to disseminate my message, is that if you look the femoral, or if you look cartilage, it changes first in femoral side, and bone changes more on the tibial side. It's more like if you want to see these group-wise differences, it's really important that where you take the specific. So again, both are changing, but the dynamics and the temporal changes are different on different anatomical components. So that is the thing that I should have been able to say.
No, I think you did say it. I think yeah. You pointed to the differences between the people. And the two people.
Other questions?
Sorry. You also mentioned the term, I think, subchondral bone erosion. And like I scanned, micro CT scanned a bunch of Walter's rats at some point, and I think somebody's scanning them now, but from Kelsey Collins' model, the diet-induced obesity model. And what we saw in the micro CT scans was a lot of what I would call a bone erosion, which is not something I see on a human OA, like a CT scan of human OA, but it does not look like that. So I'm curious your experience with spotting bone erosion in like specific animal models. Are you talking about that sort of like almost like an inflammatory arthritis erosion? More so than
Do you mean like this kind of a local erosion or like a global joint wide erosion?
like a local erosion, like a eating away of the.
So the bone erosion that we see here, I don't think we see like really interesting, awkward, erosive changes on the rabbit model. But sometimes on those rats, and what actually happened on the last really promising trials that we repeated that again, and something happened around the ligaments, and there we saw these huge erosive bits, which are probably the just bone marrow lesions. I'm not sure, but sometimes you can see those kind of lesions, but they're not, I wouldn't say like too typical.
And can I ask one? I'm curious your choice of the collagenase induced OA. Like you talked about a few different models of OA here. What do you think we should be working on? And because they each come with different features, right? So
I kind of at the end, I have been thinking this, and like one of the reasons why I think it, again, the collagenase induced OA, it has a really strong inflammatory flare when you do the induction. And I don't think it's like a normal, if you think how to model human disease. But at the end, you don't do permanent destruction on any structures. So you could test therapies on that one. And I think that kind of justifies the use of that model. So it's also at the same time, what do you want to do with that model? And what is the question that you want to answer? If you want to understand more kind of a post-traumatic osteoarthritis, I like this non-invasive rupture model a lot these days, but again, it's then mechanical. And if you think on those phenotypes, you need to do sometimes aging models, and Then the obese models, if you're interested on the metabolic, but on the metabolic, I think we are a little bit skewed, like, is it only the overweight or should we look also? What is the driver of the metabolic OA? And maybe it's also something else than the weight. But there's not like a single good OA model for all the OA.
Well, quickly following up on that, in some of the work that we have done, it would very much suggest that in the obesity model, it's not related to weight or additional loading. It really would suggest that it's the metabolic household that you change systematically in an obese animal compared to a thing that kind of goes back to.
This is exactly what I kind of meant that when you want to do metabolic OA model, you cannot just look like that. Do I have obese animals? But there's probably something that we don't know even what to look at. Kind of figure it out that it's other ones that get to metabolic OA.
Yeah, I thought, Kelsey Collins at the very beginning had a very clever model with the high-fat sucrose diet, where all animals got more obese in the sense that they increased the body fat percentage, but some did not gain a lot of weight and some gained a lot of weight. And in fact, when we separated the heaviest ones and the lightest ones had the same weight as the control, but they had more body fat and less lean body mass. But they were the same as the very high fat ones in terms of Mankin score and bone degeneration. So you have the same weight with different obesity and you're affected. And I always thought that was an interesting, of course, you see one species of rats, whether or not it happens in other animals is a different question. But I had a couple of different questions. At the very beginning, you were talking about cell deformation measurements that you made and then related them to certain observations inside the joint. And I think because you have quite a bit of deformation of the cells, I assume that was static loading and then you measured the cells.
Like a steady state. Then we applied the 10, I think it was 10 megapascals.
Yeah.
And kept it for 20 minutes or 15, 20.
Kind of like what Josh did in 99. Yeah. Because Baba O2 in our group, she now developed this system where we can collect data from cells relatively quickly. And so she would do dynamic cycling. Then when you load, then you show exactly what you saw, cell deformity. But then when you unload, it jumps back and then goes back and forth. And then I thought, that's really wasteful for a cell to change shape that quickly all the time, every cycle. But then we realized once you were about beyond 20 cycles, the cartilage was still deformed, but the cells will not deform anymore. And I'm not quite sure how cells do that. Then the other interesting thing was when you then measured calcium signaling, you saw that at the beginning, when the cells deformed, and then, when they didn't deform anymore after cycle 20 or so, there was no calcium signaling anymore. That doesn't mean there was no other signaling. But I think one has to be a bit careful about looking at static results of cell deformation. Of course, that's, sometimes the military service, you stand around for 2 hours and don't do anything, but normally you walk and, you have to sit.
Maybe you have the kind of this 20 is magic number, like we have been sometimes trying to do, like how much impact you should have to maintain bone mass. This 20 jumps might be for cartilage cells, for anabolic, kind of a biological outcome. But why we had to do the static, I think it was the best thing that we could do on that time.
No, I agree. And the dynamic loading, when I say cyclic loading, it's still slow,
Yeah.
you know, it's about one cycle every 5 seconds, and then when we do the imaging at the high load or the low load, we have to stop the
Yeah.
loading for a couple of seconds to acquire the images, and then the cells still, there's some creep, but then you have to develop algorithms to follow that, but.
Yeah.
The other question I had, I thought was really interesting is, you notice the ACL transection. You showed there are these changes in the tibiofemoral, but not in the patellofemoral joint. In fact, you said patellofemoral joint, it almost looks like it's recovering.
Yeah. For the proteoglycans.
Yeah, in terms of proteoglycans, yeah. And you know, the knee joint has these different compartments, and you reminded me of, so it seems like a lot of stuff happened in tibiofemoral joint when you cut the ACL, and not much in the patellofemoral joint. And we saw kind of the opposite when we did a muscle weakness model. So when we weakened the quadriceps muscles, we saw a lot of OA development in the patellofemoral joint, but virtually nothing in the tibiofemoral joint. And there, I think, you know, there exist the possibilities that different parts of the joint are very distinctly affected. And I thought it was interesting that you saw that, you know, in the tibiofemoral joint for the ACL transection. But I'm not sure if that maybe was a recovery or a possible recovery of the cartilage, or if just nothing happened in that compartment.
Or maybe there's like muscle regeneration going on, and that has an effect to the patellofemoral compartment.
The other thing that I always like to bring up is when we talk about bone and cartilage, because when I came to Calgary and did this neurophysiological motor control work with Andy Hoffer, I did it on the cat. And then when Cy Frank suggested I should do a post-traumatic model, I stayed with the cat because it was the most simple. I was working with cats, so we cut the ACL in cats. And then Steve Boyd, who is not here, he followed us because we followed some animals up to 12 years. Because the interesting thing about cats is, in contrast to rabbits or to dogs, where this is done, cats completely recover their electromyographical activity after 4 months, goes back to normal, their muscle forces go back to normal, their kinematics goes back to normal, their kinetics goes back to normal, which in the dog it doesn't do when you cut the ACL. The dog limps for the rest of their, well, at least 4.5 years, according to Brand. And but the cat fully recovers. And the interesting thing is, then Steve Boyd for his 12 years would take these things, and we never ever saw any change in bone. And the cats, after 4 months, you couldn't tell which side was anterocclusal or transected. And after 12 years, they started to become symptomatic. They started to limp.
After 12 years.
12 years. Yeah, lots of money from CIHR. and then the cartilage was completely gone, but the bone looked good. And so
Still looks good.
Yep. And so, well, according to Steve Boyd, I didn't do that. And to me, it kind of suggests, you know, that when you talk about cartilage and bone, I think different animal models might be different.
Oh yeah, they are.
And one has to be a bit careful from one, you know, from a mouse or from a cat or from a rat. Maybe speculate what might be happening in other animals. What is the rat model? What is the model? Is it a rat model that you use with Xenobi-1?
Sumo-san. Yeah, it was rat model.
A rat model.
Yeah.
Yeah. And then coming back to the collagenase, what collagenase did you use? So you used the collagenase that was affected primarily type 1 collagen. Yeah.
Yes.
Yeah. The reason is it's fine on board. The reason I'm asking is because we are looking for a collagenase where we would like to look at that in fibrotic muscles to reduce fibrosis without affecting the contractility and the contractile proteins. And we know that CFlex was used, for people that have Peyronie's disease and so. But we don't seem to be able to get that anymore in Canada, and it seems. And
So is it to prevent or induce fibrosis?
to prevent. You have fibrosis, let's say, in animals with multiple sclerosis or I guess muscular dystrophy is a better example. Muscular dystrophy, MDX rats or mice get fibrosis. You want to get rid of fibrosis.
This is something similar that I had in this grant that provided me the 5 years of freedom, but I'm not too happy with the outcomes. But Roxadus that should be antifibrotic, and I'm not sure. Maybe there's also some others we can have a.
I might have Faizan get in contact with you and see what.
Yeah.
Because there seems to be, so the one we wanted is not available in Canada anymore because I guess it was not good business. And then there's another one that we wanted that's available, but it's only for human use. You are supposedly not allowed to use it in animals.
Okay.
I don't know why, but anyway, any help there would be appreciated.
Yeah.
Okay, any last question for Dr. Finnila?
Last comment. Last comment. Finland. I heard on CBC radio this morning or yesterday morning, Finland is what?
9 times the third happiest country.
It's the happiest country in the world, 8 years in a row.
Oh, 9. Which one? Ninth.
Nice. Well, in Canada on CBC radio, they were saying it's the number one,
Yeah,
8 years in a row, or 9
9 years.
9 years. Okay, sorry. And the other thing that I didn't hear this morning, but I heard that several times, Finnish students regularly score the highest in the entire world in mathematics.
I don't think anymore.
That's what.
Now, the last time I heard that was a couple of years ago, maybe, but they did always super well.
They have changed the whole grading system on elementary school, so we don't pretty much score anything anymore.
It's too bad. I was just wanting to suggest to all students, study math, be happy.
Yes, I think
If you're sad, just study with the math.
I think the kind of a fundamental idea is that we try to remove this kind of a like comparing. That you don't compare. We don't give grades for that reason that you start to kind of compete just for sake of having grades. But it's much more like that. Do you really know your math?
So, do you have also the same like in Norway, where in cross-country skiing, they don't rank you before you are about 10 or 12 years old, but when kids race, there's no winner, there's no loser.
Yeah.
We have that in Finland as well.
No, I don't know for cross-country skiing, but for other things, I think we are not exactly like that.
No comparison.
Yeah.
Love that. Happy country.
All right, with that, let's thank